Well, welcome viewers.
One second, sir. 1 second.
Okay.
Yes, sir. We are live now.
Welcome viewers. On behalf of Acp India Chapter, I welcome you all here again in one more update on cancer awareness. This is the month dedicated to the cancer awareness, what we have started on 4th of February, which was the World Cancer Day. And the program has been started with the cancer in women. And today is very much important third program in the series after the hemato-oncology. We are going to discuss today the cancers induced by tobacco. And I am really very happy, and Acp India chapter is also welcome our chief guest of the day, Dr. Suryakant. So Dr. Suryakant is a professor and head of department in pulmonology at KGMU. At the same time, he is also he has also been the national president of Pulmonology Society. Now he is immediate past president. And apart from that, he is having a lot of other honors in his credit as well as publications and fellowships. He has also been awarded the FACP. With this welcome note, I will request Dr. Suryakant to inaugurate the program with his word of wisdom and inaugural words. Over to Dr. Suryakant. Before I give this program to run by Dr. Divya Saxena, I will request Dr. Suryakant to inaugurate the program with his word of wisdom.
So, namaste to everyone. Thank you, Dr. Anuj Maheshri, the wonderful friend, and of course, the dynamic leader of the American College of Physicians India Chapter. He is the governor right now. And of course, he's a very well known organizer for so many conferences and so many webinars and eminent academic events. So I'm really thankful and privileged to inaugurate this very important webinar in the series of Cancer Awareness Month. Everybody knows that 4th February is being, of course, celebrated as World Cancer Awareness Day. And the whole month is being celebrated as the month of lung cancer and so many other cancer awareness day. This is the third series as told by Dr. Maheshri, and this is basically focused on the tobacco. You say tobacco is the single product which is the most harmful to the human being, to the whole mankind. There are a lot of ways and means by which we are using tobacco in this country. Maybe chewable tobacco, non-chewable tobacco, smoking form, and so many other forms. But we will be surprised to know that there was no tobacco in India before 500 years back. The date back is only 500 years. It is basically the Portuguese who brought this tobacco into the Akbar regimes. And during the Akbar regime, they were allowed to cultivate and to of course, produce tobacco in the country. And later on, Jahangir actually put some taxes on that. And later on, marketing and of course, taxation becomes the power of the every emperor, every government of the country, so that we can't rid of tobacco till date. If you just see the ill health hazards of the tobacco, in nutshell, we can say there is no organ or system of the body which is not having any harmful effect of the tobacco. Overall, in nutshell, I can say that tobacco can lead to 40 types of cancers. Yes, my dear friends, 40 types of odd cancers, starting from oral cavity and going to the rectum. All cancers, all main cancers, they have been correlated with the tobacco. Maybe oral cancer, maybe cheek cancer, maybe tongue cancer, maybe upper airway cancer, maybe pharyngeal cancer, maybe laryngeal cancer, maybe lung cancer, maybe carcinoma of stomach, maybe carcinoma of prostate, maybe carcinoma of kidney, maybe carcinoma of rectum, colon, everything. So this tobacco has become a synonym of cancer now. And cancer, as you know, it's a very important cause of mortality in our country also and globally also. You see, I have been writing against the tobacco production, tobacco cultivation, tobacco sale, processing, everything for the last 4 years to the Prime Minister of India, to the Health Minister of India, to the Chief Minister of Uttar Pradesh, and to the Governor of Uttar Pradesh for banning all these kinds of practices of tobacco from production to the sale. You see, once upon a time, when Atal Bihari Vajpayee was the Prime Minister, probably it was 2002 or 2003, when he started, you see, disseminating the thought, why can't we get rid of this tobacco, and in place of this poison, we can cultivate the smell of the flower, the khushbu of the flower. So he was of the opinion that the land, the cultivation area, the farmers, the whole industry, the manpower, the laborer, this all should be converted for the production of flowers and scent. And when a lot of farmers, the so-called big farmers, when they visited to the Prime Minister and when they opposed this move, then he said, please now stop this poison game. Now you should switch over to us. Anyway, after 2004, he was not Prime Minister, and that's why the story went on like this. Now the problem is that tobacco kills, everybody knows, but all the governments, they're part and parcel of you see, tobacco industry for gaining the revenue from this. And for this revenue myth, I will also tell you, there was one of the committee which was made by Indian Council of Medical Research and gave the presentation to the expert committee of the parliament. And then this was sent to the parliament. The report was sent to the parliament. This shows that total revenue generated by tobacco is 1 lakh crore. But the expenditure of the major 3 important diseases caused by tobacco is more than that. But nobody is able to learn, nobody able to analyze such kind of this revenue myth that tobacco is giving revenue to the country, and that's why it's important for the progress of the country. Anyway, the fraternity people, the chest physician, the physician, and of course, every doctor in this country, maybe dental surgeon, maybe the physician, maybe it's a general surgeon, maybe oncosurgeon, everybody is now facing the menace of the cancer. Oral cancer is the #1 cancer, and lung cancer is the most dreaded cancer in this country. And we are facing this challenge. Now, I'm really thankful to American College of Physicians India Chapter and its governor, Dr. Anuj Maheshwari, and whole team for making a focus on the tobacco-induced cancer on this 18th February 2022. So I wish a great success for today's program. Thank you very much for inviting me as a chief guest. Thank you very much.
Thank you for the kind words. And before you go, please stay with us because you have to be in the session for chairing lung cancer session also. And before we go for the lamp lighting, I will also request Dr. Sengar to say a few words as a guest of honor. And then I will request that both the chief guest and guest of honor, and we all, those who faculty are here, they will be joining the virtual lamp lighting. So over to Dr. Sengar for a few words. Dr. Sengar, can you listen me?
Yeah.
Yes, please.
Hi, good evening. Dr. Maheshwari, good evening. Dr. Surkan, sir, good evening, sir. I met you in Jhansi. It's a wonderful, wonderful data you gave regarding the tobacco production. Jahangir, Ragwar, I didn't know about the long history. Sort of, I could call it ugly history. And naturally, tobacco is, as you said, 40 types of cancer and other morbidity and mortality are responsible being caused by the tobacco, like hypertension, myocardial infarction, bladder cancer, and other things. and a lot of spitting around is spreading around. All the government offices are they have stains of spitting, and the tobacco is responsible for this dirt. So definitely let us put together and let us all unite together to put pressure on the government and show the data to the government that the tobacco is more dangerous. The myth of this revenue really is nothing in comparison to the expenditure we made on cleaning the things and curing the disease. So I'm really grateful and thankful to Dr. Maheshwari, the ACP chapter of the ACP, the India chapter, for making the guest of honor. And I think let us start the program. Start with the lamp lighting, and I would not stand between the audience and let us hear from the horse mouth. Over to Dr. Maheshwari, and I think first session would be started by Dr. Dilip Kumar. So over to Dr. Maheshwari. Thank you very much.
Yeah. Dr. Divya, please ask for the lamp lighting to Ankit.
Good evening, all of you. A very warm welcome on this ACP platform to all the esteemed guests and esteemed faculty from all over India. So let's start the scientific session with a holy tradition of Indian culture by worshipping Saraswati, Goddess Saraswati, the goddess of knowledge and wisdom, and by lamp lighting. So please join us for this virtual lamp lighting. Ankit, please play the.
Ya kundendu tusharhar dhavala, ya shubhravastravruta, ya veena varadanda vanditakara, ya shweta padmasana, ya brahmachyuta shankara prabhrutibhi देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्.
Thank you very much, all of you. And with the due permission of our ACP Governor, Dr. Anuj Maheshwari, let me take all of you to the scientific session, the most important part of today's program. And for the very first session, I would invite the chairperson, Dr. Segna, to please chair the session and to introduce the speaker of first session. Dr. Segna, over to you.
Dr. Singer.
Dr. Singer, I'm really sorry.
Yeah.
MD, DM, Nephrology and ex-member MC, ex-member National Board Examination, HOD, Department of Nephrology, Principal MLB Medical College, Jhansi, and he is also a Director of MLB Paramedical College, Jhansi. Over to you, sir. Please introduce the speaker of our very first session.
Thank you, Dr. Divya. This is Dr. Dilip Kumar Acharya, a very renowned surgeon. Everybody knows him. He has got many things to his credit. He is a national chairman, IMA Cancer Tobacco Control Committee. He is honorary professor, IMA Academy of Medical Specialties. He is professor of surgery, Sri Aurobindo Medical College. He is a patron voice of tobacco victims. Ex-honorary secretary, Cancer Society of Madhya Pradesh. Honorary secretary, Say No to Addiction Foundation. He is secretary, trustee in Indore Surgeon Research Foundation. He is ex-president, Alumni Association, MGM Medical College Indore. He's got many awards to his credit. Like he has received many awards like IMA CT Thakkar National Award for Outstanding Community Service 2019. Most important award is Lifetime Achievement Award October 2019. He has been ex-governing council member, Association of Surgeons of India. He is ex-National Vice President, Indian Association of Endocrine Surgeons. He is ex-National Vice President, Association of Thoracic Surgeons of India. He is ex-executive member, Indian Association of Surgeon Oncology. He is ex-president of Indore, Madhya Pradesh, state branch of both Indian Medical Association and Association of Surgeons of India. His presentation at many national and international conferences. So, sir, over to Dr. Dilip Kumar. Sir, over to you, sir. Everybody knows you very well, and I want not stand between you. Let us hear from the horse mouth the hazards of the health hazards of the tobacco. So, over to Dr. Dilip Kumar Acharya. Thank you, sir.
Thank you very much, sir, for your kind introduction. At the outset, I'd like to convey my sincere thanks to Dr. Anuj Maheshwari, the governor of ACP, Dr. Divya Saxena, the chief organizer of today's event, and my chairperson, Dr. S. Sanger. The topic has been well introduced and very well communicated by Dr. Suryakant, who is a very learned speaker himself. And there are so good learned co-speakers also to this faculty. So I like to start with saying that IMA has been working in Cancer Tobacco Control Committee because we have over 3,75,000 members, and we have been trying to get more and more doctors into tobacco control, because we all know what tobacco menace is the problem. I'll shift on to my talk. Just hold on, please. We all know, as Dr. Suryakant has very rightly said, tobacco affects the body right from top to bottom, head to toe. But today we'll be discussing more about the oral cancers, problems of it. We all know in India, it's almost 1/3 of the Indians, they use tobacco in one or the other form. Maybe it's smoking cigarette, bidi, or chewing tobacco, which is the highest in the world in our country. A study has shown that 42.4% of all men and 14% of all women use tobacco in one or the other form. That is overall 28.6% of all adults. Economic cost has already been worked up that whatever the government earns, it spends much more on this than for the treatment of the health hazards of tobacco. The Global Adult Tobacco Survey is usually held every few years. So the one which was held in 2016 and 17, the reports came in 18.
Excuse me, sir.
Yes.
Sorry to interrupt. Actually, your slide is not moving. I think.
It is moving in my end.
No, it's not moving. Can you make it in the slideshow mode?
Visible now?
Not yet, sir. Can you reshare again?
I think I'll do that. Go to new share. Is it visible now?
Yes, your slide is visible, but it's not on slideshow mode.
The full screen?
No, it's not in full screen mode, sir.
Okay, I'll do that again. Yeah. Well, I think it should be visible now.
It's visible, sir, but it's not.
I'll see if it is changing now.
No, sir, it's not
No.
changing.
At my end, it is changing.
So do one thing first, make it on the slideshow mode. Then after that, you can share that the same slideshow wala screen.
Okay, I'll try and do that first. Hold for a minute. Sorry for the disruption. I hope I'm visible now.
Yeah. Your video is visible, sir, but slides are not.
I'll see again. When I go there, it again comes back to this same.
So go to full screen or a slideshow mode.
Yeah, I'm on full screen mode. Can you see the slide changes?
No, sir.
Visible and changing now?
No, no, sir. So can you please share your PPT with me on WhatsApp? I'll share it with the technical team.
Okay, give me 2 minutes and I'll get it done.
Yeah.
Sure. Sorry for the disruption.
No,
Meanwhile,
it happens.
technical glitches are always there. We can't help
Yeah,
it.
yeah.
So, just hold on, please.
Yeah, sir.
I want to do WhatsApp.
Yeah, please WhatsApp it to me. I'll share it with Ankit. Ankit, please play from your side. I'm sharing.
Okay, ma'am.
I'm really sorry for the glitches.
Have you shared it, sir?
I'm just opening my with this thing. Yeah, they're attaching it.
Jesus.
It is going in the meanwhile. Yeah, it has been sent.
Yeah, I got it, sir.
Yeah.
Yeah.
Okay. The meanwhile, I'll continue with the thing. Says tobacco, as Dr. Suryakant has rightly said, came to our country just 405 years back, 100 years back, but it has swept the country, and each and every people in the country is using it. Unfortunately, even my colleague doctors who are supposed to know the best, the knowledge, have the best knowledge about the health hazards of tobacco, are using it. In my city, Indore alone, we lost 3 doctors in the last 2, 3, 4 years because of oral cancers and tobacco related problems only. The cancer only I'm talking about. So that is the menace that. Okay, we'll start from here. Yeah, thank you very much, Dr. Divya. So what this shows is that people are interested in this thing. They do use a lot of this thing. Next slide, please.
Technical team, please keep forwarding the slide. Keep moving. Yeah.
Okay. Now the important slide about this is a busy slide because the slide screenshot of that. But what it shows that more and more people are becoming interested in quitting also. So it is not that the people are quitting up. And the important side, the second part is that last survey gets one was done in 2009-10. The second was done in 16-17. And there has been almost 6% reduction in cigarette consumption in our country, which is an important step. That the work of the government, rules, regulations, the work by the NGOs is showing results. Next. I was telling you, The 49% smokers and 32% smokeless tobacco users were advised by healthcare providers. Now, while it should be that 100% of the smokers should be advised by healthcare providers to quit, it is not being done. Why? Because some of us are smoking or using tobacco ourselves. Secondly, we don't have time to talk to our papers about it. But it shows 92% I believe that because of all this, it causes serious illness. And even believing that it causes serious illness, people continue to use tobacco in one or the other form. Next. Next. I'll just think it is not a smokeless tobacco alone. It is a smoking tobacco, smokeless tobacco in one or the other form being used daily by people. Next. Now it is because we have a woman, this thing, Pink Mission also work with us. So that even many women are smoking. The thing was previously it used to be that only the village users, people were smoking, but now even the girls, they are smoking. When if you visit the hostel rooms of the girls, medical students, college students, they are smoking a lot. Smokeless tobacco is also on the rise. Unfortunately, smoking is going down, but smokeless tobacco is increasing. Next. So about 1.3 million deaths occur in India every year, but we all know everybody doesn't die. So it is 90 million people are suffering, and we know that one person in the family suffers. It is the whole family which gets devastated on only economic, not only economically but other socially also. So it's next. So the Indian scenario is 1.5% of deaths in 1990 were because of tobacco, but now in 2020 we have almost 14% of deaths due to tobacco related only, and it causes 50% of all cancers in men, 25% of cancer in women, and 90% of oral and lung cancer are because of this thing. India has unfortunately, very unfortunately, that we are topping the world in the oral cancer list. Next. One of my posters, which shows a pair of cigarettes. It is one of the International Creativity Award also for this thing. I see this what says according to ICMR, out of 100 teenagers smoking today, 50 will eventually die of tobacco-related diseases only, and that death is going to be an early death also. Next. So cigarette is a lethal cocktail of horrifying list of 7,000 chemicals, 600 poisons, 69 carcinogens, and it contains a lot many other things. Next, which is next, please. Yeah, it has cancer-causing chemicals. It has toxic metals. It has poison gases which are not at all required for the body, but they are all harmful to the body also. Next. They say, I've been smoking for so many years, nothing has happened to me. But one must remember that it is a cumulative effect ultimately, which has a thing. If you cigarette, one pack of cigarette a day, a smoker will inhale 73,000 puffs of dangerous chemicals. One has to understand that. Next. So, and out of the 69 carcinogens, 11 are the group 1 carcinogens. They are the most dangerous and they are known to cause cancer in the body. Next. And according to University of Minnesota, it is that because I say people say that it's not at all, I'm not addicted to tobacco, but it is more addictive than heroin, 1,000 times more potent than alcohol, 10 to 100 times more potent than barbiturates, and 5 to 10 times more potent than cocaine or morphine. And many of the things are banned in our country, but tobacco is not at all banned in anywhere of the world. Next. Coming to the health hazards. Next. It is tobacco. Nowadays, we all talk of NCDs, non-communicable diseases. And tobacco is the root cause of this non-communicable diseases because of physical inactivity, unhealthy diet, tobacco, and harmful. They call all cancer, diabetes, cardiovascular disease, and other things also. Tobacco is the root cause of NCD also. Next. Well, we have a lecture on lung and cancer and tobacco. But way back in 1964, only the first surgeon, Luther Terry, had informed people that tobacco causes lung cancer. The thing has been known for almost 50 years, more than 50 years now, but still people continue to smoke and die because of lung cancer. Next. Talking of because we can make in India, we have more of chewing tobacco. We can make it from a distance that this person is a chewing tobacco per user. All the bad stains can be seen. Next. The acids are gone. Next. Yeah, they come out with a bad smell, halitosis, and that causes a bad breath also. Next. Even the tooth are stained, so we can make out the next. The periodontal, the gums infection is always there. Necrotizing gum infection next. Details door next. Even rheumatoid arthritis, Gatia or whatever you call it is much more in tobacco users. Next. It causes alopecia also, which is a hair loss of the tobacco users, causes that also. Next. Lungs, we know because the smoke is inhaled, maybe of BD or cigarette, causes asthma, breathlessness, COPD, that is chronic obstructive pulmonary disease, recurrent infections, and lung cancer. Next. There are two, we say that if a person has a lung cancer, he is ultimately going to die in some short time. But if a patient has a COPD, chronic obstructive pulmonary disease, he has to continue living with it. They don't die so well, but they are living like hell, because the moment they lie down, they have problems. They cannot breathe properly. So they are worried about that. Next. Tobacco and heart. It causes a lot of angina, ischemic heart disease, recurrent MI, cardiomegaly, changes in conduction also. And people, especially people under 40, are more potent because they have a heart attack if they are a smoker. Next. Next, please. Next, please. Now, one of the studies have shown that people who smoke have a high blood pressure, high cholesterol, and they can expect to live 10 to 15 years lesser than their own counterpart who are non-smokers or thing. This study has shown 10 to 15 years. Other studies have shown that the tobacco users live 5 to 10 years younger. They die younger than other people. But this is a study which shows 10 to 15 years early deaths. Next. Next, please. The tobacco causes narrowing of the arteries, blockages, gangrene, Berger's disease. Next, please. So we, as a surgeon, we see a lot of Berger's disease patients, and we have to keep on amputating. I remember a patient when we did amputation of below one side. He came to us after a year with the same problem on the other side because he continued to smoke, didn't stop smoking after even losing a limb also, lower limb. Next, please. Next, please. So the people who continue to smoke, they have a 400 times, 100 times more chances of coronary artery disease causing a stroke, 20 times risk of death from undiagnosed coronary heart disease, 20 times more peripheral artery disease, and 400 times more chances of aortic aneurysms. Next. Tobacco and breath can cause hemiplegia, TIAs also. Next. Next, please. People do not know that tobacco is one of the leading cause of impotence. Also, almost 85% of patients of impotence are tobacco users. Next. Skin changes, it causes wrinkling, nail changes, psoriasis. Next. Next, please. It causes osteoporotic and degeneration in the bones also. Next. Even pancreatitis, because recurrent tobacco and alcohol together, they cause a lot of problems with recurrent infection of pancreatitis. And we know that recurrent infection of pancreatitis, chronic pancreatitis, can lead to insulin also, yes, usage also, and diabetes also. Next. It even can be a threat to the eye also. It can cause early cataract also, and even macular degeneration, which can cause blindness also. Next. Coming to the main topic of tobacco and cancer in India, we have about 10 to 12 lakh cancer patients every year, but out of that, 4 lakhs are directly related to tobacco use only. Next, we have breast cancer and cervix cancer also. But one has to understand that 40% of cancers are preventable. But very unfortunate thing is, even in India, people come to us, to the surgeons, the doctors, in a very late stage. So it is they come to us in an advanced stage, and we are not able to do much help to them. So prevention is the best for us. Next. So apart from tobacco, it is a diet and obesity, which causes lifestyle, which causes 33% cancer, alcohol, occupational 5%, 5 biological 5, family history, other things also. So now we can say that cancer is becoming a lifestyle disease also, because tobacco, diet, obesity, alcohol, they are all lifestyle things. So cancer is becoming a lifestyle disease also. Next. So Dr. Surikant had talked about 40 different types of cancer, but UICC, on broadly speaking, they've given us the 12 to 13 different types of cancers that are directly related to tobacco only. And like in oral cavity, we can subdivide into lung, tongue cancer, cheek cancer, other things also. But cancer, different parts of the body, it is all the cancer which are directly related to breast cancer also, caused by tobacco use. Next. Next, please. Coming to oral cancer, oral squamous cell carcinoma is 6th most common cancer. It is very common in males and even 3rd most common in females also. In US, approximately only 33% of cancers are tobacco in like oral cancers, while in India, there are only 30% of oral cancers occur of all cancers. Next. So we see like more than 1 lakh patients new year. Unfortunately, Bhopal is one of the had been proved to be the one of the highest cancer rate of oral cancers in the country, especially with tobacco and cancer, because that's next is Ahmedabad. Next. So the cause of oral cancer, the most important is tobacco. Second is areca nut or betel nut, supari, which what you call it. Supari is again, as I said, is a class 1 carcinogen. And together with alcohol, tobacco is more deadlier also. Apart from that, a new HPV virus infection is also a cause of oral cancers. And there is a lot of countries have started giving anti-HPV vaccine, like in cervix cancer to the for prevention of oral cancer to males also for that purposes. Next. So of 86% of oral cancers in the world occur in India only. And out of this, 90% of all oral cancers are because of chewing tobacco, which is typical for the Indians. Next. See, look at this picture. They are all patients of oral cancer, but the important thing here is look at their age. Next. Younger and younger patients are being affected by oral cancers, which is the main problem. India is called the most cancers. People still come to us in such an advanced stage. Look at the picture, ghastly photos. Next. Lung cancer, my learned co-speaker will be talking about it later in time. Next. Breast cancer even is caused by tobacco is used in smoking. Next. Even secondhand smoke can cause a breast cancer. Next. Even infertility is directly related to tobacco use also. It can cause decreased fertility, low sperm count. In females, it can cause early menopause, increased incidence of abortions also. Next. It affects the menstrual cycle also. Their periods are much more painful. Next. Even high miscarriages rates are there in tobacco users, smokers. Next. Even ectopic pregnancy rate is very high in people who are smoking during pregnancy. Next. So effect on children, like the mother is a smoker, and if she is carrying, it looks like that even the child in the womb is smoking. Next. It causes the mother smoking during pregnancy can cause premature delivery, stillbirth, weak child, congenital diseases. The child will have cleft lip palate. Next. They can have even if the newborn born to a smoker mother, they have irritable also. They have behavioral problems when they grow up also. Next. They have more of chance of dependency, drug dependency also. Next. Even squint, like you said, I'm not looking London, going Tokyo. It is 26% more chances of a patient newborn getting a squint if the mother is a smoker during pregnancy. Next. Cleft lip and palate is very high incidence in of the children who born to a smoker mother. Next. So if you look at this, right from hair loss top to bottom, the whole almost, as Dr. Surikant has highlighted earlier also, each and every organ of the body is getting affected by tobacco, and cancer, different types are getting affected. Next. So I've been asked to cover up an examination of full oral cavity also. So see how nice pink looking oral cavity looks like. But unfortunately, next. In India, what you see is usually this type of oral cavity, all stained teeth, with the number of fibrotic areas and other things also because of tobacco use. Next. So when we come to examination of full oral cavity, the oral cavity includes right from lip to the uvula. So one has to look at it, look at the upper lip, lower lip, both the cheeks from left and right side and from inside, then tongue, and then below that. Next, please. Hold the tongue in the thing, pull it out, rotate it lateral on the lateral side, both lateral side of the lateral and right lateral, left lateral border of the tongue, because usually what happens, it is in the tongue, the cancer is occurring on more on the lateral border. And even with the indirect laryngoscopy, you can see that thing. Then uvula and soft palate and hard palate has to be examined. Next. And bimanual palpation to note the any lymph node also, and this thing. Next. And this is the draining area of the whole of the neck, which has to be examined systematically. Next. So any ulcer more than 3 weeks, leukoplakia more than 2 centimeters in size should be a cause of worry. Next. So sign it can be a sore throat, it can be persistent pain, lumps, everything. It does happen that many a times the patient visits the dentist first. They say it's a loose teeth, they take out the teeth and then comes up that after some time you have a growth there, which comes out to be an oral cancer. Next. So cancer of gingiva and buccal mucosa, you can see that a big area is there. Next. The carcinoma tongue, very common, seen more on the lateral sides. So a small ulcer, someone says it's like it has been bitten by a teeth, but sometimes it comes out that it's a cancer there. Next. So even white patches and red patches, which we call leukoplakia and electroplakia, of different types, are one of the precancerous conditions also. So one of the thing is one should mouth open and try to rub it up. If they do not get removed by rubbing, people will just say, I just had a milk, so it is lying there, or I had a curd, it is lying there. But it's not that, is a leukoplakia is there. Next. So there are different varieties of leukoplakia, which is nodular type. Next. And then you have a varicose leukoplakia, which is growing this thing, which is very not fast growing, but malignant transformation is very high, to almost 70 to 80%. So these are, next please. Erythroplakia, that is the red spots also, they can get converted into malignancy. Next. And even submucous fibrosis, which is very common with areca nut users, that is the mouth opening becomes less, and they have malignant transformation rate of 2 to 8%. Next. So the mouth opening becomes less, and that can be a cause of worry because you are not examine the interior of the mouth also. Next. Lichen planus reticular reticulopenia is also a precancerous condition. Next. Even erosive lichen planus, the redness like this can be a malignancy, can get converted to malignancy. Next. Tobacco pouch keratitis also, people is known that people they use to park the tobacco use. They mix up, we call it quid, QUID. That is, they mix up the tobacco leaves and spices, other things also, chuna, katha, and all those things, and park it between the cheek and the teeth. And it is known that they get a cancer there and there only. Next. Even a smoker, reverse smoking can cause cancer. Actinic keratitis or recurrent cheilitis can also lead to this thing. Next. Oral field calcification, the whole of the oral cavity becomes cancer-like. Next, field effect is there. So all these are coming to the leukoplakia, erythroplakia, hyperplasia, dysplasia, puncturing submucous fibrosis. They are precancerous condition. Whenever we get a patient, we said that if we can get a patient in a precancerous condition, that's the best. We can give the best treatment to them. We can even prevent them from converting into malignancy. But unfortunately, patient comes to us in late stage. Next. So that all these things, erythroplakia, there are different ways of conversion into malignancy. We'll not go. Next, please. Next, please. So for that, what we say, if you are able to quit, best and foremost thing, if one is not able to quit, we request them to do a self-examination. And even a doctor and a nurse can be trained to do an examination of the oral cavity, which is easily visible to all of us. What is cheap, you don't have to spend any money. Normal, light, easy, cheap, reliable, reproductive, and highly sensitive and specific. Next. Next, please. So screening can be done with, next, please. So even self-examination can be taught to people. Next. Next. So we just ask them to rinse the mouth, wash the hands, open the cavity, and see all the steps. And if you see a abnormal white patch or red patch or swelling in the mouth, consult a doctor. Next, please. The technique is very simple. Next. There's a posture you have to systematically, you have to examine the neck from both the sides, stand in front of a mirror with a good light, torch and this thing, systematically feel this thing, feel that the upper lip, lower lip. We put a light inside the mouth, oral cavity, and see this thing. This poster I displayed in a World Cancer Congress, World Conference on Tobacco and Health, 2008. Dr. Harshvardhan was also there in that meeting. Next. Next, please. Now coming to the last part of the talk, is how to quit. Because as I said, people want to quit, but they need some support also. So next. When WHO has come out with the Framework Convention on Tobacco Control, FCTC, that was the first health treaty of WHO, and a short form that they have come out with Empower, which is the main gist of this thing. And I want to have the one always offer help to the patient. Next. So as a health worker, we have to our duty to offer help to the tobacco users if they want to quit. Next. So we have to strengthen our health system to help people to quit. Next. Next, I already talked that people want to quit. Next. Just keep on moving. Next. So now it has been well studied that tobacco is why it causes addiction, how it causes addiction, and everything is well documented. Whatever I have talked is all available in literature also. But it is that dopamine is whenever a person smokes or uses tobacco, it reaches the nicotine, it reaches the brain, and it releases dopamine, which is like saying a feeling of satiety, and that's in the whole pathway. So if you want to curtail, you have to cut the pathway also, reward pathway also. Next. Next, please. Next. Next, please. So nicotine affects the ventral tegmental area that way. Next. So as I said earlier, nicotine, which is a nicotine substance with the tobacco, which is the most addictive. It causes because it releases serotonin, dopamine, norepinephrine, and which is next, please. Next, please. So what happens basically is if the nicotine level goes down, the brain gets a craving. So people use more tobacco. They either eat tobacco, chew tobacco, or they smoke, and then it gets dopamine release. So the cycle keeps on continuing the whole day. So next, please. So as I said, in general, 70% of the world people want to quit, 40% have quit trying, but have tried to quit, but only 7% succeed. The success rate is very less. That's the reason we want that people should not start using tobacco. They should not get hooked up onto this thing. Next, please. So dependency, it is a chronic disease now. World, the thing, ICD-10, International Code of Diseases 10 has given that nicotine dependence is a disease now. And therefore, we as the doctors have a duty to treat the disease. So it's a disease of love. So we have to understand why people smoke. Not going to tell us next, please. So nicotine is 25% reaches in brain in 15 seconds. Life is 2 hours. So the lethal dose also it has this thing. Next, please. We try to judge how the dependence of the person is because we have a Fakestrom test. Next, please. And there's a score of 9 to 10 shows it is very dependent. Next, please. So for that, when non-pharmaceutical approaches, smoking cessation, the first and foremost thing is cold turkey. That is, a person decides, I'm going to quit. I go to Mandir Masjid, Gurudwara, I bow my hand in front of the God and say, I'm quitting from today. Or there's a birthday, my child has a birthday, my wife has a birthday, and I decide to quit. So there's almost 80 to 85% people in the world, they quit that way only. But the unfortunate thing is, they said, it's very easy to quit because I've quit 10 times. That means the 11th time they've started. So again and again, one has to restart also because of that thing. So for that, cold turkey, individual counseling also is important. Then one has to support of the family, group, and friends also required. Behavioral therapy, even hypnosis, acupuncture has been tried for these purposes. Next. But if you want to quit, one should set a quit date. Tell family, friends that even if I ask for a cigarette, don't give me that. Anticipate, plan the challenges you'll face. You'll face like, I want to, if I come out of my house, go to left corner of the street, and I see a tobacco shop there, I should take the other route so I don't come across the shop only. Remove tobacco products and all that, and talk to your doctor for help. Next. WHO has come out with saying 5 ways. The next, please. We have IMA is also working with all these health professional doctors and trying to train them on 5 ways only, that if they want, ask the patient if he's interested, tobacco user or not, or if he's interested, and advise them health hazards of tobacco, assess whether he'll like to quit or not. And then you have to assist them also by counseling, by medication also, and then arrange follow-up also, because people quit for a few days and they start again. Next. Then there are 4 days like delay the urge, drink water, do something else. Next, please. So with the next, after the cold turkey method, we have a pharmacological therapy also. That one is a NRT. We call it nicotine replacement therapy. That is helpful in cessation. Next, please. It is because the use of NRT doubles the effectiveness of tobacco cessation efforts and reduces individuals' withdrawal cost also. Next, please. So NRT, but the NRT only deals with physical addiction. It does not work when used as the only method of saying. So one has to have a physical liking for this also. One has to decide first and foremost thing mentally also that he wants to quit and remain quit all his life. Next, please. For NRT, we have chewing gums in our country, 2 milligram, 4 milligram available across. It is a OTC product also. The nicotine patches have come up. So if it's a patch you are using, if you're a heavy addiction, then start with a 21 milligram patch, change it every 1 day, 24 hours for 14 days each, then convert it to 21 milligram, 14 milligram, then 7 come down to 7 milligrams. Even nasal spray are going to come in the market. Next, please. So these are patches, just apply them, they remain there for 24 hours. So as I said, the cycle goes that when the nicotine level goes down, you have a craving. So this will supply the nicotine in a very small amount. And so the other hazards of tobacco will not be there. Next. Another drug which commonly used is Champix or Varenicline. In India, it is marketed by Pfizer. The only thing is that if you start, suppose I want to quit on 1st of next month. So for 5 days earlier, I should start the drug and then continue for some more time after that. Next, please. Another drug is bupropion hydrochloride, which is available as Zypen. This is also helpful in diagnosis and treating the distinct addiction. Next, please. Next. But pharmacotherapy can double or triple the likelihood of successful smoking, but it is not a magic bullet. One has to understand that one has to be mentally prepared himself. His family support is also very important, and then he can remain quit. Next, please. So we have patches. Nothing. Next, please. So we have non-pharmacological and pharmacological ways to help you up also. I'm just talking about e-cigarette because e-cigarette came up in between. That even Delhi, one of the schools they checked up the bags of the students of 8th and 9th standard, and the number of students had a e-cigarette in their bags earlier. So IMA and many other associations wrote to the government, and finally Indian government health ministry has banned the use of e-cigarettes and other harm reduction thing, heat not burn like the products like that. Next, please. So I'm mentioning e-cigarette just next, please, to show that it can, because it does contain tobacco in one or the other form. Next. And it is just that other tip, you have a bulb which lights up when there's a battery inside, and when I inhale, someone inhales this thing, you have isopropyl alcohols that emit smoke also. Next. And now the different this things, the latest one is like the pen drive also. The parents may not understand that my child is using a e-cigarette. Next, please. So when they use an e-cigarette, they come out with this also, smoke also like that. Next. Next, please. So because it is vaping, it is also known as ends or nicotine delivery system or vaping also. Next, please. Which has been banned, but we have to see that it remains banned also. And the people, because they do not get it from the market, gray market like that. Our presentation on e-cigarettes, we have been working against e-cigarette in 2015. Next, in Abu Dhabi. Next, please. And again in Malaysia also. Next, please. In some countries do say that it has some role, but WHO doesn't agree that it has any role in tobacco use, harm reduction in tobacco is this thing, addiction. Next, please. So with that, I close this thing. And once again, sorry for the delay. This thing on the slides has shown everything. Thank you very much.
Thank you, sir. Thank you for the lucid presentations. And we all know that tobacco is responsible for a major disease burden in India. So we all should put in all our efforts to spread the awareness by whatever way we can do, so that we can at least contribute towards saving some lives from this menace. So with this, the first session ends. I think Chairperson Dr. Sengar is not here. So as soon as he joins, we'll definitely take up the questions in the end of these sessions. So for the next Technical team, please show the memento. Ankit? Yeah. Dr. Sanger, please accept the memento of token of appreciation from our side, from ACP side.
Thank you very much, ma'am. Thank you.
Yeah. Dr. Acharya, please, sir, accept a small token of love from our side.
Thank you very much.
Yeah. Thank you so much. So coming towards the next session of the day, I would invite Dr. Neeta Mishra to please chair the session and to introduce the speakers for our next session. Dr. Neeta, over to you.
Thank you, Dr. Divya. Yeah, I'm so happy and very much privileged to introduce speaker of the evening, Dr. Anshuman Kumar. He is a MBBS and from Patna Medical College and MS from AMU Aligarh. He's done neurosurgery, cardiovascular and thoracic surgeries, plastic surgeries, and he has been senior resident in Mulchan RRKR Hospital, New Delhi. He's MCH gold medalist, University or Cancer Institute, and he has also done so many accolades, so many things, MRCS from Edinburgh, MBA, so many things. He has held so many posts from Institute, Director Oncology Services in Asia, oncology in north and east areas. He has got so many awards. The Rising Star Award in Oncology by Times of India for received Vidyut Bhushan Samman, and he has also received Oncologist of the Year 2014 by the Ministry of State for Health. Professional membership he is having the Royal College of Surgeons of Edinburgh, European Society of Surgical Oncology, and Indian Association of Surgical Oncology. So privileged to introduce Dr. Anshuman Kumar. Thank you. Dr. Anshuman Kumar.
Thank you so much. Thank you, Dr. Neeta. I think it's better to start the session without much of the delay. Ankit, can you allow me to share the screen?
So you have already rights to share the screen. You can share.
No, it's not an option.
Yeah, it's there, sir. You can share. You can see the green. Yeah.
Ankit, can you see the slides?
No, sir, not yet.
Ankit, it's not there. Option is not there to share the screen.
It's there. There is not any particular option we have given to anyone. So everyone having the share screen option.
Ankit, please help him out.
I will just do one thing. I'll just make you the co-host, so if you can see that.
Yeah, that's the option. Yeah.
Now check, sir, once again.
Yeah. And rejoining it. No, Ankit, it's not there.
No, sir.
See, if you touch the share screen option, there are only Microsoft Drive, Google Drive, Box, Photo, Documents, Web URL, Camera, and Share Whiteboard. That's all.
So for that, sir, first you have to open your presentation.
There will be the share screen.
No, share screen option is not there, ma'am.
Oh,
At the bottom.
That's what I'm asking for.
At the bottom, Anshuman, it's a green signal.
Yeah, no, ma'am. Last time we presented through the same app because that's the only available the host or co-host. As Ankit
No,
is already
it's not like
option
that,
co-host.
No, sir, you're getting
So
wrong.
you're
Actually,
co-host
it's not
now.
like that. Right now, I have made you the co-host, but it's not like that because इसके पहले भी Dr. Dilip को भी मैंने co-host नहीं बनाया था, but he can share.
Ankit, please make him the panelist.
I already मैंने उनको co-host बना दिया.
Then Dr. Anshuman, can you please share your slides with me on WhatsApp? Let it be shared from technical team sides.
That would be better.
Any of you are on Telegram?
Ankit, do you use Telegram? He can share on Telegram.
No, you can share here also in the chat box also.
Actually,
Attachment.
Okay. Anshuman, can you please mail me? Meanwhile, if you allow, Dr. Anshuman, can we start the third session?
Yeah, sure.
Yeah. So please share with me your PPT on mail.
On mail, I'm sending you on mail. Yeah.
Okay, thank you. So for the third session, I would invite Dr. Suryakant sir, if you are here, sir, please chair the session and introduce the speaker. I think he is not here. So let me take the privilege to invite our next speaker, Dr. Shahid Choshi. He is a consultant pulmonologist, Max Hospital, Vaishali, and he has been a clinical observer, Singapore General Hospital, visiting fellow National Cancer Center, NCC, Tokyo, Japan. He has a IBER-STAT certification, Royal Brisbane Women's Hospital, Brisbane, and he has so many publications in his name. That is, one is rare multisystem inflammatory syndrome in young adult from COVID, subsequent SARS-CoV-2 infection, and another is esophageal intramural pseudo diverticulitis, diverticulosis presenting as non-resolving pneumonia, a sinister cause diagnosed by EUSBFNA. So over to you, Shahid Choshi, for your presentation, that is lung, tobacco and lung cancer. Over to you, Dr. Shahid, please.
Okay. Thank you for the lovely introduction. I'll just share my slides. So without wasting much time, so very extensively, Dr. Acharya has already told that tobacco doesn't only affect lungs, it actually affects the entire body. But being a pulmonologist, almost more than 15 years, 17 years in pulmonology, I will be focusing more on lung cancer and its correlation with the tobacco. So as per WHO, the fact is that
sorry to interrupt, sir. Can you make it on the slideshow mode?
Is it fine?
Perfect, sir.
Yeah. So according to WHO fact sheet, tobacco kills up to half of its users. When I say kills, that doesn't mean that rest of the people are not suffering from any tobacco related disease. It is contributing to heart disease, it is contributing to gastritis, it is contributing to peptic ulcers, bleeding. So it's not always that it is killing, but at least 50% people are getting killed because of tobacco use. And over 80% of world's 1.3 billion tobacco users, they live in low or middle income group countries. So it is an actually big concern for the country like India. And these are commonly affected organs. One of them is oral cavity, throat, esophagus, voice box or laryngeal carcinomas, lung cancers involving airway, trachea, everything. And myeloid leukemias, blood cancers, kidney cancers, bladder cancers. So tobacco, its use, whether you are chewing the tobacco or patient is smoking tobacco, it is affecting the entire body. And 80% of lung cancer is contributed to use of tobacco. So rest 20%, it is the disease of non-smokers. But in 80%, that is the majority of lung cancer is because of tobacco use. And a smoker, in a smoke, 7,000 chemicals are almost there, and at least 70 are known carcinogens in the smoke of a cigarette. And given this entire burden and tobacco, there are governments putting up a lot of taxations. They are making them expensive. The packets are embedded with suffering patients or oral cancer patients. And there is a screening program. Unfortunately, we don't have a systemic protocolized anything regarding screening or a systemic screening about lung cancer or any cancer related to tobacco. But in developed countries, countries like USA, they have a screening protocol for patients who are a smoker in the age group of 50 to 80 years, who have smoked 20 pack years and have not left before 15 years. So these patients qualify for screening for lung cancer, active screening for lung cancer. And for this screening, they use LDCT or low dose CT scan for screening. For patients above the age of 80 years, they don't recommend this CT screening because their life expectancy and definitely the management of cancer will be different for people who are above 81 years. So why it is important that we learn, because as I have discussed with senior Dr. Anuj Maheshwari, that we have to keep it around lung cancer and clinically important. So I'll discuss that why it is more important to diagnose it early. So in 2017, we carried out a study at our place and we screened almost 500 patients who presented to our center. That was published and accepted by National Board of Examination. And we found that 63% of patients at our center presented in stage 4 carcinoma of lung. And 14.9, almost 15% patients were in stage 3A and 15% patients in stage 3B. So if you take it from the point of view of management, almost 93% patients presented in stage 3A, 3B or stage 4, which is non-resectable tumor, which is you can only offer them palliative care or chemoradiotherapy, but they will never be cured of the cancer. And surprisingly, most of the patients had several or one or the other comorbid conditions, and that led to delay in their presentation, delay in their diagnosis. So 40% of patients had diabetes, 35 patients, that is 40% patient had COPD, 13% patient had CHF. So all these symptoms, all these comorbidities actually are confounding factors. So if a patient presents with chronic fatigue, which is a common symptom in cancer, but it can be actually a common symptom in diabetes also. It can be a common symptom in heart failure. It can be a common symptom in COPD. So because of these confounding factors, their diagnosis got delayed. So 93% patients presenting in advanced stage of cancer, it's a lot of burden. On the contrary, if you diagnose this situation, this cancer in stage 1 or stage 2, definitely you can give them curative surgical options. So it is very important to diagnose it. So how do we diagnose it? A common presentation of lung cancer will be worsening of cough, that is persistent cough. It can be dry, it can be productive, or it can be blood stained. We call it hemoptysis. Then chest pain is one of prominent symptoms. Malaise, weight loss, low feeling, dyspnea, hoarseness of voice, and facial swelling. These are common symptoms. Unfortunately, the symptoms will be limited and they will be overlapping with other diseases. So these all symptoms you may find in tuberculosis or bronchiectasis, necrotizing pneumonia. For any chronic lung infection can actually have these kind of symptoms, because the fever in these conditions can be absent. In diabetic patients, fever can be absent. In patients with these conditions, fever can be very, very mild, low grade. So it might go unnoticed. So these are confounding factors, and it is very important that if you find any abnormality and if your patient's symptoms are not improving on your diagnosis and treatment, then definitely you should work up early. So what are the armamentarium we have for diagnosing a lung cancer? First and foremost is definitely history. Then sputum cytology. Almost 3 samples are to be tested for sputum cytology. This is one investigation which is very, very less utilized in our country. Then X-ray, CT scan, PET scan, and bone scan. These are imaging studies which will tell you or which will help diagnosing a lung cancer. Unfortunately, on X-ray or plain CT scan, cancer can present like cavitating mass. It can confound with tuberculosis diagnosis. It can confound with diagnosis of fungal pneumonia. So imaging will tell you the abnormality, but what is the cause of this particular lesion? That has to be diagnosed on tissue basis. It should be, if it is tuberculosis, it should be microbiologically confirmed. It should be confirmed with gene expert or PCR or anything else. And if it is the malignancy which is suspected, then it should be tissue diagnosis. For tissue diagnosis, we have needle biopsy or fine needle aspiration. Then we have CT-guided transthoracic biopsy. Then for central lesions which are placed closer to airways, we have bronchoscopy and biopsy. For patients who have central mass lesion abutting the central airway, then we can go ahead and do endobronchial ultrasound and endobronchial ultrasound guided FNAC. This particular instrument can be used through the esophagus also for posterior mediastinal masses, or if there is something which is in the lower mediastinum abutting the esophagus, then definitely EUS is one thing. Endoscopic ultrasound and the FNAC guided by EUS can be of diagnostic purpose. Then radial EBUS is a small instrument which has 2 millimeter diameter, and it can actually approach peripherally placed lung lesion. So even pleura-based lesions can be accessed through the central airway by the use of radial EBUS. Mediastinoscopy, fortunately, after the development of EBUS and extensive utilization of EUS, EBUS or radial EBUS, mediastinoscopy has gone out of fashion and it is rarely needed now. For patients who have pleural fluid or pleural masses along with the lung cancer, they can be diagnosed with thoracoscopy, pleural fluid analysis, or VETS biopsy. There are other advancements for the diagnosis of lung cancer. These advancements are actually at sporadic centers available in India. In our country, things are available nowadays. It's not that we don't have these facilities in our country. Electromagnetic navigation, lung point technology to pinpoint the peripherally placed lesions and approach them through the airway. So this is approachable, this is doable, it is available in India. Then robotic bronchoscopy, nowadays it is being talked a lot. This is not presently available in India, but robotic bronchoscopy has been invented and it is being used very often in Western countries. Most importantly, whatever the biopsy tissue is obtained, it has to be subjected for immunohistochemistry, because if we talk about the management of lung cancer, if we talk about the chemotherapy of lung cancer, we cannot compare the present chemotherapy with the 17 or 20 years ago what chemotherapy used to be. So now we have targeted therapy, which I will discuss in the management section of it, my talk. So immunohistochemistry, genetic mutations, these are the developments, these are the tests done on tissue biopsy or tissue material, and that will define the specific type of the cancer and whatever the target medicines can be used. These two, genetic mutation and ISC, these are the most important investigations to be carried out on the tissue. So broadly speaking, lung cancer can be divided into small cell lung cancer and non-small cell lung cancer. NSCLC and small cell cancer is SCLC. So 85% of lung cancer is because of non-small cell lung cancer. And out of this 85, 30% is squamous cell carcinoma, 70% is non-squamous cell carcinoma. And majority of non-squamous cell carcinoma is adenocarcinoma. As a physician, as a general practitioner, and a first point contact of a patient, I think this is the brief classification of lung cancer which we should always refer to and which should always be remembered. Because otherwise speaking, there are several other varieties classified: large cell carcinoma and undifferentiated carcinoma and poorly differentiated carcinoma. So to simplify it, just two types: small cell carcinoma 15%, 85% non-small cell carcinoma, then non-squamous cell and squamous cell, then adenocarcinoma, which is the commonest of all. So if we talk about management, there is for any management of lung cancer, there are two important things which has to be defined. That is what I always keep on telling my patients. One is the type of tumor, whether it is squamous cell, whether it is adenocarcinoma, whether it is large cell tumor, the type of tumor and the stage of tumor. As I have mentioned, that delay in diagnosis of lung cancer is very prominent, very troublesome in our country, and that is exhausting a lot of healthcare resources. It is challenging and costing a lot of human resources and human life as well. So diagnosing early is important. If you diagnose non-small cell cancer in stage 0, the surgery will be curative. The patient will be cured of the lung cancer. Now, we are talking about curing a lung cancer, and that is only possible in early stages of it. So stage 1A, 1B, surgery is the first thing. And if there is any residual effect or residual lesion left, then adjunct chemotherapy or radiation. The same stands true for stage 2A and 2B of non-small cell lung cancer. If we talk about advanced disease, the stage 2, the neoadjuvant chemotherapy, the chemotherapy which is given just prior to surgery, and after there is reduction in the size of tumor with the chemotherapy, you can go ahead with the curative surgery as well. For unresectable tumors, the chemoradiation is the first line of therapy, then radiation therapy. And for superior sulcus tumors, surgery followed by chemoradiation or radiation. Until stage 3A, early stage 3A, because now they have classified stage 3 into stage 3A1 dot or stage 3A.2. So there are sub-classifications now included in the lung cancer and management of non-small cell lung cancer. So for even 3A, they recommend surgery as the first line, surgery followed by radiation and the second step, or radiation therapy alone. But when we come to stage 3B, stage 3C, or stage 4 of non-small cell lung cancer, it will be sequential or concurrent chemoradiation or radiation therapy alone. For stage 4, definitely surgery is out of question. It's just the palliative care or cytotoxic combination, or whatever the mutation we can find in the tumor, whether it is EGFR or ALK or TKI inhibitor, tyrosine kinase inhibitor, these kind of drugs can be used. I'll come back to this advancement in the newer chemotherapies because these are targeted chemotherapy drugs which have lesser side effects. They can be taken oral and their effect can be seen within 3 months. So for non-small cell cancer, at times the PD-L1 can be judged, and if you find that the tumor shows more than 50% PD-L1, then pembrolizumab is the drug which can be used as the first line therapy. If PD-L1 is less than 50%, then platinum-based regimes like carboplatin or cisplatin can be used as a chemotherapy. If the chemotherapy first line fails or there is recurrence later on, then definitely second line chemotherapy can be used. And all these drugs, pembrolizumab or nivolumab, are available in India and being used extensively. For small cell carcinoma, it is classified in limited disease and extensive disease. So for limited disease, small cell carcinoma, chemoradiation is first, and combination chemotherapy alone can be used as an alternative, followed by surgery and definitely prophylactic cranial radiation, because small cell carcinoma has tendency to metastasize to brain. So prophylactic cranial irradiation is important. For extensive disease, it's chemotherapy or combination chemotherapy followed by radiation, and thoracic radiation for patients who respond to chemotherapy. And prophylactic cranial radiation definitely will be also given to patient of small cell carcinoma with extensive disease. For recurrent disease, there is chemotherapy or immune checkpoint modulation. Nowadays, when first line chemotherapy fails or the patient doesn't tolerate second line chemotherapy, then definitely immune checkpoint modulation or immunotherapy can be used for carcinomas. So these are different genetic mutations which we look for when we diagnose lung carcinoma with tissue biopsy. So EGFR or endothelial growth factor receptor, this mutation is one of the commonest mutation found almost 10 to 35% of patients in non-small cell carcinoma. Then KRAS or ALK or ROS or HER2. HER2 is primarily a mutation which is found in breast carcinoma, but in 1% of carcinoma lung, this mutation can be seen. And if you find any of these mutations in the tissue diagnosis of your patient, then patient is a candidate for oral chemotherapy. And that is the best advantage of it. Because when a patient is on oral medication, when patient is getting chemotherapy at home on daily basis, once daily dose, so patient doesn't feel that he is so sick or he is fighting cancer. And that's very, very important. So if we talk about EGFR mutation, it is most commonly seen in adenocarcinoma, the patients who are non-smokers. It is more common in Asian population. It is more frequent in female population. Almost 34% of adenocarcinoma show this EGFR mutation, and 6% of squamous cell carcinoma shows EGFR mutation. So these patients who show EGFR mutation are actually candidate for erlotinib, which is an oral anti-cancer drug. Then tumor protein 53 is another very frequently found genetic mutation seen in cancer cells. It is present in 43% of squamous cell carcinoma and 35% of adenocarcinoma. And KRAS, 30% non-small cell cancers, more common in smokers, 14% of adenocarcinomas and 5% of squamous cell carcinoma. This information is actually important to update your knowledge about lung cancer. So nowadays, when I was in medical college, diagnosing lung cancer was actually most often in stage 3 or stage 4, and it used to be a death sentence. Either patient used to succumb to the disease, or patient used to have so much of side effect with the toxic chemotherapy that he used to die of side effect of the chemotherapy. But nowadays, with these genetic mutations, it's easier for patient and it's easier for management of lung cancer. So we call it precision medicine. If you see that there is EGFR mutation, there are 7 or 8 drugs which are available. And out of these 2 drugs, erlotinib and geftinib, these are very often and very commonly being used in our country. Then if you find ALK mutation, then ceritinib or crizotinib, both the medicines are extensively being used in our country. For patients who have got ROS1 mutation, Ceritinib or Crizotinib is available and it can be used. For patients who have BRAF mutation, Dabarafenib, or these are quite a tongue twisters because their names are common and most often they are antibodies. So Teramatinib, this is also available. But very often I get references from my oncology friends that this patient is responding very well. We have done PET scan after 3 months. The primary tumor has completely regressed. But now what we see is that there is development of right side pleural effusion. And probably it is tuberculosis because of the immunosuppression of chemotherapy. So you just evaluate. And we find out that despite of investigation, there might be that ADA is also positive, patient has exudate and lymphocytic pleural effusion. Despite of the fact, patient doesn't have tuberculosis. All these precision medicines or genetic mutations and oral anti-cancer drugs or newer anti-cancer drugs, they have different kind of side effects. So those side effects should be kept in mind when you are using it on your cancer patients or when you are evaluating a cancer patient from your colleague for other lung manifestations. So these medicines like Dasatinib, which is very often used in our center, I think extensively also being used in other cancer centers as well. So this particular salt, Dasatinib, can cause recurrent pleural effusion. It can cause chylothorax. It can cause exudative pleural effusion, ADA positive effusion. So that doesn't mean that patient has got tuberculosis. It might be a chemotherapy related pleural effusion. It causes organizing pneumonia. It causes PAP. So while the primary disease is improving, patient saturation is going down. Patient's lung shadows are still increasing. And now the oncologist and patient both are perplexed that cancer to theek ho raha hai, except that saans bahut phool rahi hai. So you know that these drugs are giving side effect. When we talk about side effect of any of the drug, not only cancer drugs, the side effects are mostly seen in 1 to 10% of patients or less than 10. If side effects are more than 10%, the drugs cannot be in the market. They are not approved for clinical use. But even 10% is very, very common. So if you use Dasatinib in 100 patients, in 5 to 10% of patients, you might come across with any of the side effect. The same way, Crizotinib patient might come with diffuse alveolar hemorrhage. So patient's primary cancer is regressing, still patient is having massive hemoptysis or recurrent hemoptysis. In fact, even pneumothorax pneumothorax can be a presentation of side effect of Crizotinib. So you can't say that the smokers will be COPD patients and smokers will be cancer patients. So you may say that this pneumothorax is a secondary pneumothorax to COPD. But in fact, you should know that Crizotinib per se can cause pneumothorax. So you might have to change the anti-cancer drugs. So it's not only about diagnosing lung cancer. It is very important that we diagnose it early. The same way we manage it early and manage it with the precise medication so that patient doesn't suffer with various side effects. Because if the patient's ECOG score or the performance score is low, the oncologist is not going to start chemotherapy. And if you diagnose a case in 3rd stage or 4th stage, chemotherapy is the only left option. So it is very important that we diagnose early and we subject the tissue material for ISC, for genetic mutation, for EGFR and ALK mutation, so that we can offer the best possible medication to a suffering lung cancer patient. Similarly, the pembrolizumab, it can present like pulmonary embolism. It can give a side effect of pulmonary embolism. A cancer patient is always high-risk patient for developing pulmonary embolism because of his weakness and comorbidities and other manifestation. He might be bedridden. So there is another chance of pulmonary embolism. There is another risk factor for pulmonary embolism. And to complicate further, pembrolizumab per se can cause pulmonary embolism. Myasthenia gravis is one of the side effects of pembrolizumab. So we need to see what drugs are being used when your cancer patient responds to primary disease with the primary therapy, but there is worsening of symptoms or there is development of another symptom. I think we have talked enough about tobacco and lung cancer. From my talk, the most important conclusion is we should abandon the use of tobacco. There are people who will support tobacco. There are government and agencies which are benefited with the taxation on tobacco, with the selling of tobacco and use of cigarette and tobacco. But as a clinician, we have pledged to reduce the suffering of human being, and abandoning or motivating people to stop using tobacco and smoking is one and foremost step towards the well-being of mankind. Thank you. If you have any other query, or if you want to contact, you can log into drshahidjoshi.com, which is my website. One of my oncology friend has this mission, and he has developed this website, I Can Care. So it is a cancer care website, and they are deeply into quit smoking and quit tobacco campaign. They have certified course from recognized by the University of Gujarat. So they have they have trained hundreds of doctors who can actually learn through these courses of 3 to 4 days, and they can start practicing quit tobacco clinics. Thank you.
Thank you, Dr. Sharad, for such an elaborative talk, and it was really an eye-opener for all of us. Thank you once again, and I request you to please stay till the end of session to address if there are any questions in the chat box. So I request again Dr. Neeta Mishra to please chair the session, which is still pending, of Dr. Anshuman Kumar, and technical team, please show the memento for Dr. Shahid Choshi. Please accept this small token of appreciation from our side, Dr. Sharad.
Thank you, ma'am. Thank you.
Over to you, Dr. Neeta, for the session.
Yeah. Yeah, Dr. Anshuman.
Yeah, thank you, Dr. Neeta. I'm sorry for the technical glitch. And Ankit, do you have presentation now? Perfect. Perfect. Thank you, Dr. Divya Saxena, and all members of American College of Physicians for just not just symbolizing the World Cancer Day, but prolonging the session and seminar for 1 long month. And my topic is oral cancer knowledge, opinions, and practices. Just to understand the burden of oral cancer, US population, just out of all malignancy, only 3% are oral cancer. Compared to India, it's 30% of oral cancer constitute to all the malignancy. Next, please. Just see the trend of epidemiology of oral cancer in India. You can see the blue line as well as the age. In India, majority of the cases of oral cancer in the young age group. And blue line showing Buccal mucosa. You can highlight Buccal mucosa and gingival buccal sulcus, means lateral compartment complex cancer are more common in India because of habit, quid, khani, gutka, and everything. While the Western population has central compartment, tongue, floor of mouth, and medial part of the lower alveolus. That are the most common. This actually gives outcome and prognosis different from the Western world. Next, please. Socioeconomic status, if you see the income, education, and occupation in India, majority of the sufferer, 80% of the sufferer belonging to laborer or farmer group. Next, please. The real facts behind all these problems are lack of public awareness about signs and symptoms and risk of oral cancer, absence of routine oral exams in at least 70% of the public hospitals. They don't have oral cancer examination or a screening facility in the setup. Absence of prevention and early detection by healthcare providers. Nobody is even bothered, even in the dental clinic. And for that, we have started a concept of training dental doctor, ENT, and MS surgery doctor. We have trained more than 7,200 doctors for early detection and ablation of the pre-malignant lesion. Next, please. If you see the cases versus oncologist ratio in India, India has only 2,000 oncologists for 10 million patients. Just see the discrepancy, how you can treat all the cancer cases in early stage and give the better outcome. Next, please. Health budget, although it was previous slides, this time budget has been revised, but this is just an eyewash. It constitutes less than 2% of the entire budget we are spending on health, that you can't achieve a good cure rate. Next, please. We have only 19 tobacco cessation clinic in 2002. We have increased it, but they are not functional. National Tobacco Control Program in 2007 and 8, they started Kotpa and everything. And in 2013, Gutka was banned in 24 states, where we have published international paper. That was just an eyewash, because masala and tobacco product both are separated. Name is not now Gutka, but it's available freely in the market. Next, please. The failure of national policy is the major reason behind everything. Oral cancer incidence in Delhi, an alarming scenario. This paper was published. An incidence of oral cancer in India is still increasing, even after ban of tobacco. And surrogate advertisement using pan masala and mouth freshener adds to promote Gutka products. Gutka is still being sold openly in the national capital on the roads. Next, please. The causes of failure of national policies are corruption, non-inclination of Indian government, and non-compliance of execution authority. This is the fact. Next, please. To add further, 70% of the Indian population live in the rural area. We have only 0.6% hospital beds out of 1,000 in India as compared to 6.8% in United States. Number of doctors 0.6 in India as compared to 5.3. Healthcare expenditure we have already discussed, and out of pocket expenditure in India is very high as compared to public health program or insurance company. Next, please. Next, please. And to add everything, all the spices come from Baba therapy. All nooks and corners of India, Baba rampant to treat cancer by hooks or by crook. They are charging for it. Next, please. How, as a clinician, we can turn the wheel around? Indian oral cancer, the first important thing, can we treat as per the Western literature? After going through this slide, your concept will be changed. Just compare Western world with the India as far as the habit is concerned. In Western world, smoking is the most common habit. In India, chewing tobacco or quid is the most common. Age, in Western world, it's middle or early age. In India, it's young age. Sight, in Western world, tongue and floor mouth, that is central compartment. In India, it's buccal mucosa and gingiva buccal sulcus. Oral submucous fibrosis, it's common in Indian patients. It's almost absent in Western world. Presence of oral submucous fibrosis actually delay the diagnosis of early oral cancer. Socioeconomic status, usually are 70 to 80% patients belong to lower or middle socioeconomic class. In Western world, they belong to middle or high socioeconomic class. Stage of detection, in our country, 70 to 80% oral cancer are being diagnosed in T3 and T4 stage. In Western world, it's T1 and T2. We don't have non-compliant strict national protocol in our country. They have very strict protocol. Health insurance is personal to everyone in India, barring few. It's common to all in European country and barring few in US. Load, it's very less in Western world, very high in our setup. Next, please. Can we contribute something? Yes, we can contribute in prevention of oral cancer, early detection, reversing the scenario what we are facing today, availability of the treatment, uniform protocol, and improving the cure rate. Next, please. Medical practitioner united, we can turn the wheel around. If it's an MBBS or BDS or any branch of the medical practitioner, we can combine, form a group. We can detect early symptom, which mimics the common oral problem, which are non-healing ulcer, bleeding gum, loose teeth, ill-fitting denture. Dentists especially have enough role in detecting early cancer. They have dental chair and good light and mirror to examine the oral cavity thoroughly. Next, please. These are the things we have to go through while actually we want to contribute to the oral cavity scenario in reversing the scenario. Next, please. Exams on the oral cavity, just move the slide faster. Just meticulous examination of the oral cavity. Ankit, please move the slide. Meticulous examination of the oral cavity require only gloves, one torch, and one tongue depressor. Next, please. Keep on moving. Start with the lower labial mucosa, upper labial mucosa, left buccal mucosa. Usually most of the clinicians right-handed, then right buccal mucosa, then hard palate, then soft palate, then dorsum of the tongue, then lateral border of the tongue. And next, don't miss to examine ventral surface of the tongue and bimanually floor of mouth. Next slide. To miss any of the submucosal lesion, any of the minor salivary gland lesion, or a small ulcerative lesion with underlying base with spreading cancer in the floor of mouth. Next, please. Next. Usually, the 5S are the risk factor for oral cancer: smoking, spirit, that's alcohol, sharp teeth, sexually transmitted infection, especially human papillomavirus, and sanitation. Next. This is the common problem commonly seen in the street. Next, please. Usually, these are the component of gutka. Areca nut, derived either from leather factory, leather industry. Not it's a fresh areca nut, cashew. There's a katha, paraffin, which is derived from all the petroleum chemicals, tobacco, slack lime, and flavor. Again, aniline, and majority of them are commercial chemical product, not the actually rose or lavender kind of thing. Next, please. In the form of business, gain is cancer, sometimes life, and lot of money. Loss, it may be business and everything. This is a gutka-induced tongue cancer. Next, please. It's an interesting slide of gutka being consumed by a small kid in the lap of a beggar. Next, please. Another factor is cigarette, which is very common. Dr. Acharya was saying it's very rampant in the medical practitioner. It shows 365 days sale, and out of those cigarette, you are just starting with a kick for your zindagi, but actually you're kicking your life. That's fact. Next, please. There are many chemicals present in the cigarette. Next, please. Sharp teeth, another component which is even ignored by medical practitioner, considering as a traumatic ulcer, but frankly speaking, it may be carcinoma. Must ensure don't extract the so-called culprit teeth before doing biopsy. Otherwise, a small lesion may spread to the dental alveolus. Infection, human papillomavirus 1618 are the major culprit. Next, please. And oral hygiene is the one of the component of the contribution in the oral cancer development. Next, please. Next. If we consider oral cancer, there may be baby cancer or pre-malignant lesion or frank cancer. Next. These are the top 4 oral precancerous lesions: leukoplakia and electroplakia, OSMF, lichen planus, and other keratosis and leukoderma. Next, please. Move on fast. These are again and again. I'm saying to biopsy small white lesion. The reason being, if you biopsy small white lesion, in 30% of cases you get either hyperkeratosis, dysplasia, carcinoma, and C2, a small invasive squamous cell carcinoma. And 60% of oral carcinoma presents as white lesion. Another white lesion is if leukoplakia is homogeneous, means smooth, don't do anything, you can observe it. But if it's heterogeneous, don't leave it. Chance of malignant transformation is 1.5 to 2%. Erythroleukoplakia, there's a white and red lesion, chance of malignant transformation is higher. Must address it so that the cancer development or malignant transformation should be stopped at the right time. Next, please. OSMF is actually just white blanching thing, reduced mouth opening, but it's either precancerous or maybe hiding some cancer, and you are not able to examine the floor of mouth or retromal or trigon. Next, please. Oral lichen planus, another lesion. Next, please. How we can treat it? Chemoprevention you can do if it's not a surgical candidate. By lycopene and retinoids, there are many research and studies after that. And if it is a surgical lesion, you can remove it either scalpel, electrocortis, CO2 laser, depending on your expertise and the instrument available at your center. Next, please. Non-healing ulcer is the most common presenting feature of the oral cancer. Next. Reduced mouth opening. Next. Next. Red or white spot. Next. Premature fall of teeth. Next. Loosening of teeth. This kind of swelling, the common presentation. Next. These are the confusing lesions. You can see the traumatic ulcer. Therefore, 4 most common presentation of oral cancer: non-healing ulcer, reduced mouth opening, loosening of teeth, or ill-fitting denture. Next. When you suspect oral cancer, must biopsy, especially if the lesion is solitary and present for over 3 weeks. particularly if it is indurated, you are palpating with the pulp of the finger, associated with cervical lymphadenopathy, and in patient of high risk group. That all 5S must biopsy. Don't ignore it. Next. There are certain myths about oral cancer. Cancer spreads when touched with metal. This is myth, especially biopsy and FNAC. But fact is, in cancer treatment, usually we don't do treatment except 3: renal cell carcinoma, ovarian carcinoma, and gallbladder carcinoma. If these 3 cancers are operable based on the tumor marker and imaging facility, we can avoid biopsy. Rest all cancer, we need to prove it by cytology or biopsy. Next. Scrap cytology is outdated. No role. FNAC in oral cancer, yield is very low. Excisional biopsy, please never do. It will actually misguide the further treatment. Incisional biopsy only indicated for endophytic growth and submucosal disease. Next. Then most of the clinicians are searching for an alternative to biopsy. Frankly speaking, this is the gold standard. There's a punch biopsy, small forceps. You can keep it in your clinic, and there's a very beautiful method of doing biopsy without any crushing artifact, and you can take a good chunk of tissue, no risk of bleeding. Even physician can do it. Next, please. These are the punch biopsy setup. Next. This kind of lesion can be biopsied with this punch biopsy forceps. This kind of lesion can be biopsied. Even with trismus, you can do biopsy with punch biopsy forceps. No need for knife, no need for suturing, nothing is required. Next. Punch biopsy in process. Next. Must do label the container of the biopsy, put 10% formalin, and label the container, fill the form properly so that mixing of the specimen should not be there, and cancer patient being tagged as non-cancer and non-cancer to cancer. Expectation from oral pathology. Sometimes you get the report, you are clinically suspecting it's a cancer, but pathologist is saying something else. If you're high index of clinical suspicion, must do biopsy again. Next, please. A margin of biopsy is not actually important now in our case, but when you are doing incisional biopsy, must leave suture behind so that final surgery, that will be a kind of sentinel lamp to guide for the margin. Next. Must fill the biopsy form properly. Next. These are the problems with, if you are injecting the lesion with local anesthetic like xylocaine, vacuolation of the cells in another problem. If you're crushing with a forceps, Ellis forceps, tooth forceps, artifacts due to crushing effect can be there. Therefore, punch biopsy forceps is the most recommended technique for biopsy. Next. Heat damage, crush artifact. Next. Autolysis artifact. If you're not putting in the formalin, 10% formalin, then sample can get autolyzed with normal saline. Please don't put in normal saline if you're sending to the lab. Next. These are artifacts and these are the remedies. Next. After the biopsy, it is squamous cell carcinoma, whether it's a poorly, moderately, or well-differentiated squamous carcinoma. A staging workup comes as the important factor. There are 2 important modalities available everywhere in the periphery: CT scan and MRI. If you are staging for soft tissue or scanning for soft tissue, go for MRI. If you're scanning for bony window, go for CT scan. Next, please. Lungs, depending on the T stage of the tumor, either chest X-ray or CT thorax, and abdomen, either ultrasound or CT scan. Next, please. PET scan, people started thinking it's a magical tool, which is not the fact. It is not magical tool. Next. PET scan in oral cancer indicated only for residual disease, recurrent disease, post-surgery, post-radiotherapy, or if your suspicion finding on conventional imaging like CT scan or MRI. Because in India, there are a lot of inflammatory like tuberculosis or trauma, which can overstage the disease, which is actually after most of the EBUS guided FNA or biopsy will get only granuloma, nothing else. Therefore, don't go for PET scan in all the cases unless it is indicated. Next. These are the flow chart, how to go for head and neck cancer staging and biopsy. Next. These are the points for planning. Next. When a case comes, concept of 3M must be there. First aim is man, that is surgeon. Second is medicine, that is chemotherapy. And third is machine, that is radiotherapy. It should not be surgeon-friendly or oncologist-friendly treatment. Must plan the treatment for the best outcome of the patient, not for the doctor. Next, please. Next, please. The oncosurgeon, most of the people think that's a simple surgeon, they know to cut. But fact is, first training of the oncosurgeon is what to cut. Second is how much to cut, how much to take the margin. Next, when to cut. And when we get experience of more than 10 or 15 years, we learn when not to cut. That's the most important training of the surgeon. Next, please. Because cancer is an unpredictable disease, it has not read the textbook of David. Next, please. It's a lawless disease written in the Bible. Everyone who makes a practicing of sinning also practices lawlessness. Sin is lawless, so the cancer is. It's not localized to one organ, it's hop and prop. Next, please. Close to vital structures like tumor adherence and lymphadenectomy, while you are doing, you have to touch the major vessel and dissect all the lymph nodes. Next. This is a classical neck dissection along with dissection of the specimen. Next. Because we have been discussing jugular vein, it has been written in Quran that we have already created man and know what his soul whispers to him, and we are closer to him than his jugular vein. Next. Tumor spillage. We have to avoid cutting through the tumor and exfoliation of the cells because it actually leads to local recurrence, which is not acceptable in cancer surgery. Next, please. And it's really described by monster Rakt Bija. One drop of Rakt Bija touching the earth can give rise to many monsters. First chance is the best chance. Radiation and chemotherapy cannot compensate proper surgery. Proper surgery is the ideal answer to oral cancer treatment. Next, please. It's actually multidisciplinary approach. A team of radiation oncologist, medical oncologist, oncoanesthesiologist, reconstructive surgeon, rehabilitation team, and all the hospital management authority led by the surgical oncologist is actually multidisciplinary approach to cancer treatment. Next, please. Next. Only 2 points I want to highlight, even if you are physician. In head and neck oncology, we have to address and understand, we have to address mandible, we have to address the neck. It's also important even if you are a general practicing or practicing medicine. Next, please. In mandible, segmental mandibulectomy, marginal and mandibulotomy, there are 3 procedures. Next, please. In segmental, we have to remove one segment of the mandible, entire mandible. This slide is important for a physician. The reason being, I got called from physician that mandible is not involved. Why do you want to remove? The second line you can read, paramandibular soft tissue involvement can't give margin, appropriate margin, if you are not resecting the segment of the mandible. That's the reason of segmental mandibulectomy. And obviously, gross invasion of the mandible is the prime indication for segmental mandibulectomy. Next, please. If mandible is not involved, we can do marginal mandibulectomy, preserve the mandible, but provided paramandibular soft tissue is uninvolved. Next, please. Mandibulotomy, just we have to take the approach through mandibulotomy and reset by plating. Next. Management of neck after mandible. If neck is positive, clinically and radiologically, there is no question we have to dissect it. But neck is negative, N0, we have to take Mendel-Hall criteria for that. When to address the neck. Next, please. Next, please. Neck dissection. These are the level of lymph node. Next. Move on. Neck dissection. The comprehensive selective. MND type 1, 2, and 3. Next, please. These are selective neck dissection. Next. Keep on fast moving. This small lesion, T1 lesion. Keep on moving. The laser excision under process, excised. This is the specimen properly marked with the silk sent for laboratory, Carcinoma right lateral tongue. Next, a small suture you can see in sentinel biopsy done by a trained oncologist. He left suture in situ. Next, please. Modified chiral neck dissection. This is a dissected part. Next, please. This dissected specimen. You can see the suture so that we can take the margin around the suture, considering this is the main tumor, epicenter of the tumor. Next, please. This is the final post-op result. Next. Carcinoma right buccal mucosa, wide local excision with platysmal myocutaneous flap. Next, please. A small lesion. Next. This is the platysmal myocutaneous flap. We have published the highest literature in the world, 998 cases in the world. China has only 10 cases in the world. These are the beautiful flap we can use for the oral cavity reconstruction. Next. Flap harvested, neck dissection done. Next. Specimen dissected. Beautiful specimen with base all around. And this is reconstructed with the platysmal myocutaneous flap with good mouth opening. Next, please. This is a donor side morbidity because flap was taken from the neck where neck dissection has already planned. This is a carcinoma buccal mucosa T4 lesion. Next. Intraoperative. Next. Dissected specimen with overlying skin, unable to close outer and inner. Therefore, clover leaf pectoralis major myocutaneous flap harvested from the chest area. Next. One pedal went inside, one pedal outside, and reconstructed with pectoralis major PMMC. Next. Carcinoma left retromolar trigone, T4. Next. Classical composite resection. A specimen reconstructed the free fibula flap and jaw reconstructed in the same sitting. This is a donor site for the free fibula. Keep on moving, Ankit. It's a post-op. Next. This is classical labeling of the specimen. You can see primary tumor, level 1A, 1B lymph node, 2A, 2B lymph node, level 3, level 4, and level 5. If you label this specimen like and send it to the oncopathologist, they will able to answer your question how to decide the post-operative treatment like adjuvant radiotherapy or radiochemotherapy concurrent. Next. Laryngopharyngectomy and bilateral neck dissection because it's a smoking-related cancer. Therefore, I have shown this slide. And next slide is very interesting. Even after laryngectomy, next please. Patient was smoking through tracheostoma after 5 years cancer-free life. And this is a picture outside my hospital. On the main street, my fellow clicked the picture and patient was freely smoking through tracheostoma. Next, please. Yes, just 3 case capsule you can see in your OPD. 62-year-old male reported with chief complaint of swelling in the right side. You can see right side swelling since 4 months. FNAC is a squamous cell carcinoma from this swelling. Next, please. As I was in OT on my team doctor took the history, did examination, and provisional diagnosis made by resident was metastasis of unknown origin and oral submucous fibrosis. 2 points to highlight. Means no primary was detected by resident on clinical examination. That's the reason I am always highlighting meticulous clinical examination. And second, patient had OSMF, which actually hinders them for proper oral examination. Next, please. When I came from the operation theater, I did simply oral examination. You can see 2 spots inside the oral cavity, one in the right retromolar trigone, small lesion, and one in the lower alveolus on the same side, away from the main lesion. Next, please. Next. The 2 lesions you can see on the highlights. Next. We did biopsy. It is oral squamous cell carcinoma, 2 primary with 1 secondary in the neck. Treatment remained the same. Obviously, we did PET scan because multiple primary was there. Second lesion is non-healing ulcer. Patient took local treatment with a steroid, antioxidant, sharp teeth adjoining. What next? Usually, people think that extract the teeth. No. First do biopsy. Disprove it's no cancer, you can extract the teeth. If it is cancer, send for cancer treatment. Third case capsule is also proliferative growth, right lateral tongue, biopsy squamous cell carcinoma, imaging of choice. Because I frequently get patient with this kind of lesion, CT scan was done. No, MRI is the imaging of choice. Don't go for CT scan. Fourth and last case capsule is neck dissection. When we have to do. Actually, it was operated, primary was operated by oral maxillofacial surgeon, and he avoided neck dissection. We preferred neck surgery in always because it appropriately stages the neck. Keep radiotherapy reserved for the future metachronous primary. Most of the patients are tobacco chewer. Short and obese neck, clinical follow-up difficult. Compliance for follow-up challenge in India. Only 50% patients present in salvageable state. And frankly speaking, it increases survival rate. Therefore, must address the neck in the same sitting when you are addressing primary with the surgery. Next, please. There is a certain myth about and thought block that cancer surgery is big surgery done only by big surgeon in big hospital. But the fact is, next, it needs proper planning, optimum setup, and skilled hands. Nothing else is required. Next, please. Philosophy of cancer treatment is integrated approach for predictable outcome. Next. Integration of the patient, treating spot and primary care physician are required. Nothing else is required. Next. Where is the roadblock now for integrated approach? Next. Delay in consultation rare in metro. Affordability can be an issue, but choice is blind. Where to go for the patients? Next. Primary care physician is usually educated, well-informed, responsible, good analytical power. Delay in diagnosis sometimes happens, sometimes it doesn't happen. Next. Treating a spot consists of two things. One is hospital, and another is doctor. Hospital cost can be a concern. Crowd can be concerned both for the government as well as private. Care can be concerned at both the sides. Remember, building never cures your patient. It's a doctor sitting inside the building. He must be accessible, balanced. And we, as a doctor, why I'm saying we can change the scenario. We have only one line, one thought, one community, that is Seva Paramo Dharma. Therefore, we united can change many things. Next, please. My personal belief is it's a doctor is the most patriotic community of the world. It saved the life, saved the nation revenue. If we just detect cancer in the early stage. Next. Don't be afraid of cancer. Entire world is afraid of everything. Next, please. And we have been running many training programs for different doctors, be it say BDS, MDS, ENT, general physician, surgeon, and anyone can join for the short-term, long-term, or 1 year, 2 year fellowship or DNB surgical oncology program. Next, please. Om Sarve Bhavantu Sukhna Sarve Santu Niramaya Sarve Bhadrani Pasyantu Ma Kashid Dukh Bhag Ved. Dhanyavad.
Excellent presentation, sir. We are so enriched to have you in the program.
Thank you, Dr. Nita.
As you told now that we are using our tobacco counseling center, like we are having a tobacco counseling center in our institute, and it's functional too. And one thing I wanted to add, like if patients are getting that fear can be like if we intraoral cameras can also be helpful. Like if we use intraoral cameras to show their lesson in their
This is
mouth.
a visual act, Dr. Nita. This is a visual act. This is a mask screening, but ultimately
visual act
biopsy is the gold standard.
Yeah.
Thank you, Dr. Nisha and Dr. Anshuman for such an excellent deliberation. So with this, we come to the end of today's scientific program. There are no questions in the chat box. I would request the chairperson and the speakers, if you want to ask any question from any of these speakers, please go ahead.
Not a question, but just a statement that Dr. Anshuman has already said about tobacco being available in every street and every corner of the city, also in my city and everywhere also. So we have been working hard that a vendor licensing should come in force. Anybody who wants to sell tobacco should have a license. That way, I'm sure the use of tobacco, especially the gutka, will go down. And that will definitely, if the gutka consumption goes down, the oral cancer will definitely go down also. So with that, I think the government has to see that the vendor licensing, increase of the taxes, and all other measures which can help us reduce the tobacco use and thereby oral cancer in the country should be enforced. Thank you.
Yeah, very truly said, sir.
Dr. Acharya, just to add to this, yeah, this can be a good interim approach, but frankly speaking, this is not the root cause analysis and curing it by root. We as a cancer surgeon believe everything should be cured by root. Everything. NGO, starting from NGO to vendor licensing to doctors involving tobacco cessation and control. Why government is not able to control, ban the tobacco product entirely, not just an eyewash? The reason being, if we understand the tobacco economics, we are losing much of the life, much of the revenue than what we are getting out of this tobacco revenue. We have to understand, we have to convince and pressurize the government for that.
I fully agreed on that point. In the beginning only, Dr. our chief guest had said about this also. The point is, we know it, the government cannot stop tobacco use on day one, but government, I think government is already working on it. The alternative crops are being advised to the farmers that should go into that. As far as FCTC also, we know that every few years, 15% reduction in tobacco production has to be there. And I'm sure we have to work on all the facts together. The production also, the supply also, training of doctors in tobacco control, training of doctors and tobacco cessation, everything very important, sir, rightly said by you. But it has to be a team approach. And I sometimes say that हवा ने सबकी आहुति जरूरी है इसके अंदर तो. The government, the NGO, the doctors, everybody, the common man also, everybody has to get involved with this thing. And I'm sure as the consumption of smoking has gone down by 6% in the country, the tobacco use will also go down in some time to come. But it's a slow process. We have to see that it become fast also. Thank you very much, sir.
Yeah, one small query from for Dr. Shahid Choshi. Is there any specific lung cancer caused by smoking? Please unmute yourself, Dr. Shahid.
Sorry. So it's a squamous cell carcinoma, which is more often associated with smoking. But nowadays, we see that smokers are also getting adenocarcinoma. The incidence of adenocarcinoma is on the rise. So primarily, it's a squamous cell carcinoma, which is more associated with the smoking.
Smoking. Yeah. And Dr. Anshuman, is there any relation between HPV infection and the oral cancer? Oh.
Ma'am, 27 years back when I was at GCR Ahmedabad, and I thoroughly in 2 weeks, I got 6 cases of oral pharyngeal cancer without history of tobacco. Then my query was oropharyngeal mucosa and cervical mucosa and vaginal mucosa are the same kind. Is it a possibility? When I expressed my view or query, everybody started laughing. My view was unprotected oral sex may lead to oral cancer, because I asked history of all the boy. Everybody was involved in multigamous partner and oral sex. And after when I joined Delhi, after 8 years of my joining, it was released by ICMR. Then my interview was published in Times of India that you quoted it long back. How it's possible? Now it's again moving from oropharyngeal to oral cancer in non-smoker, no sharp teeth, no other problem, no alcohol, but and we are doing marker. P16 is a marker. If HPV induced oral cancer is there, P16 positive cancer will be there. We have done a good research on that. Lot of cases.
Thank you. Thank you so much for throwing the light on such an important subject. So with this, we can conclude the session. Is Dr. Anuj Maheshwari there? I think he's busy with some another conference and presentation there in Darjeeling. So let me take the privilege to conclude the session. It was really a privilege to hear from our diverse speakers today and learn a lot about the nuances of oral lung cancer. Thanks a lot to all the esteemed faculty for the excellent deliberation and enlightening our audience. Thank you, chairpersons, for sharing your valuable time for conducting the sessions wonderfully. And thank you, ACP Governor Dr. Anuj Maheshwari, for taking this great initiative and dedicating the whole month towards the cause. And last but not the least, a big thank to RX Events, Ankit, and to the whole technical team for all the assistance they have given to make this event possible. Thank you and good night to all of you. Let's meet again for another a very interesting CME sometime in future. Thank you, all the speakers.